as he said, some of you know me, and so I'm the college tutor as well as consultant with interest in gynecology here in Wexham Park Hospital. So today's topic will be cervical cancer. So before going to the cervical cancer, I'm just going to go through some, in between some cases as well as go to the staging. I'll be going here and there, but overall you will achieve some objectives of this session. You will know what are the risk factors, what are the varied presentations they come with, and how the GPs can refer simple things into 2-week wait pathway, and as well as you can arrange appropriate investigation and be able to make patients aware what will be the treatment options available in the gynecology cancer center. Because as you know, most of the cancers are treated in the gynecology cancer centers, and DGHs are gynecology cancer units, and we are only allowed to treat around stage 1A1 cancers, I'll tell you. So this is a bit of statistics which I have taken from the Cancer Research UK. Worldwide, I think in UK it is less. It's the 14th most common cancer in the females. And it accounts for all 2% of the new cases in UK. This is all statistics from 2017. The highest in the age group of 30 to 34, but despite that, you can see that even 9% of the cases, about 1/10, they happen in older women. So never ignore the women who come with postcoital bleeding or even irregular bleeding at the age of 70, 75, so they can present postmenopausal bleeding, and if you do an ultrasound may not detect anything down cervix, and you might, so there lies the importance of clinical examination. Okay, so some question time. We know that HPV is most important for the development of the cervical cancer. So it can be detected 89% of the cervical cancer, true or false?
False, it's 99%.
99, good. So all of you are well. Okay, and about women aged more than before 50, they develop this HPV infection around 75 to 80% of the women before age of 50. True? False?
True.
Yeah, good. Let's see. So how many years it takes around women? Some of the women have persistent HPV despite all the treatments, even the loop treatment, and then they go on to develop high-grade CIN and ultimately invasive cancer. How long it takes? 8 years, true or false? False? True or false? Okay. We'll find out. Oral contraceptive pills and smoking increases the risk of squamous cell cancers and adenocarcinoma. True or false?
True.
It is just to create an interest. I know all of you know.
True.
Any answer? True. True. Okay. So let's see the answers. So you are all right for the first two. I think it takes around, some studies have shown 10, but on an average, this is from the up-to-date. It takes around 15 years to develop. So most important is those women who have persistent HPV. You have to be careful and when you're counseling, some people are so worried that you have to tell them that it takes many years to develop into invasive cancer. And oral contraceptive increases the squamous cell carcinoma and adenocarcinoma, but smoking is associated only with the squamous, not with adeno. I mean, it's not an important question, but I thought, I don't know how to wake you up and get engaged in the topic. Okay, so then, as you all know, there are risk factors which are HPV related. So these are the HPV, and I think everybody, I'm sure You have covered all the colposcopy and topics, so you know that having early sexual activity at the earlier age increases the risk. High-risk sexual partners, STDs, early age at first birth, increase in parity, para 3 or more, increases the risk, and so on and so forth. History, it's important nowadays, more and more women are coming with multiple, they have VIN3, they have vein, and they have also CIN. So it's a common etiology is the HPV. And of course, immunosuppression and low socioeconomic status is one of the important risk factors as well. And other risk factors which are not related to HPV is again race, oral contraceptive use, cigarette smoking, genetics. Nowadays, there's a large study which showed that there is some link to the familial link is there. They thought it could be the common practices, environmental practice in the families, but more and more genetics are being researched. And the other thing is women whose partners have been circumscribed are at less risk of having cervical cancer. We don't know the reason. So HPV vaccine, a little bit about that. We started that, the program usually targeted at 12 to 13-year-old girls, and then some of the catch-up program was done to take some of the women at below 18. In 2008, we had bivalent vaccine, which covers HPV type 16 and 18. And in 2012, it included in addition to 16, 18, it included 6 and 11, which protects the genital warts. So what was the prediction? How much the HPV vaccine would reduce, we thought initially? Anything?
70%?
How many percent?
70%?
Is it CIN or cancer you're talking?
CIN.
You're right, you're close actually, 70%. But globally, I'll just say some data. Excellent. So, it is worldwide. When the NHS screening, all the countries don't have. We are lucky in UK to have this NHS screening program. So in India, we don't have. There are lots of other countries we don't have, but globally, the NHS screening program and the HPV immunization program in UK here, we have found that there is 75% decrease in the incidence and mortality of cervical cancer over the past 50 years. But how much the HPV immunization program has added to this, we don't know. Exactly, we have only some data now. So it was predicted that that will decrease 50% of high-grade CIN and 70% in cervical cancer. But after it, you can see that we have some data from Australia, that have achieved the vaccination rate of more than 70%, and they have found that there is a 38% reduction in high-risk dysplasia. So when you are doing some colposcopy clinics, you will see lots of nowadays HPV, the women who have been had vaccine in the school around 12 to 13 years, they're coming with low risk HPV. So it will be a nice audit for you guys to do when you go when you attend some of the colposcopy clinics to find out the woman who had HPV vaccine and coming with abnormal smear, what is the percentage of high risk CNL, low risk, but majority what in my observations in the colposcopy clinics, I found low. So coming to the histopathology of the cervical cancer, you see that it's a crowded slide which I've taken from the up to date. So majority 70 to 75% of squamous cell carcinoma, and 1/3 is adenocarcinoma, and you know that there are so many types. I don't want you to get involved too much, but you remember that when there is a adenosquamous carcinoma, that has very poor prognosis than pure squamous or pure adenocarcinoma. So this is a case I've just created to have some interest, so that you know. So this is anyone wants to read out, please?
I'll read it out. So she's a 34-year-old para-3 smoker and presented with persistent postcoital bleeding and instrumental bleeding for 6 months. Her swabs were negative for chlamydia and gonorrhea. She's worried and anxious as her mother had cervical cancer at 48 years. She used the combined oral contraceptive pill for contraception, and she was referred in a 2-week wait pathway as examination by a GP revealed abnormal looking cervix. She's allergic to penicillin and she has a BMI of 25.6.
So what do you think? I mean, she's referred in 2-week wait pathway, right? So you might be thinking about cancer. Because I do the 2-week referral screening triage in my hospital. I find lots and lots of women are referred because of this abnormal cervix. So I'll find out. We found varied type of. We accept it because we cannot ignore, as per the NICE guideline, if the cervix looks abnormal, irrespective of the smear, you should see these patients in the rapid access clinic. So in this case, what are the important histories and what else you will ask? One of you? Anyone?
About her smears, previous smears, are they up to date and normal?
Yeah, good smear history. Yeah, the last smear I checked, it was normal.
Any other medical problems?
Yeah, it's the same history
Any
you
other
asked.
medications?
Yeah, no, she's fine. There's no other medical problem. That's a good question. And also, you will ask, you know, in the history it says postcoital bleeding and intermenstrual bleeding, right? So sometimes, what are the causes of intermenstrual bleeding? Anyone? Causes of intermenstrual bleeding? Common causes?
Ectropion, PID.
Yeah, yeah, excellent. Like, there are loads of causes. There could be endometrial polyp. There could be
Fibroid.
Yeah.
Fibroid.
Fibroid. Yeah, if it is a intramural, you know, intracavitary small fibroid causing, but most of the time you'll see that apart from cervical cancer, you find lots of other non-benign causes of intermenstrual bleeding, including even sometimes they are not taking the contraceptive pills. But most important is you rule out, you see her and examine her, and so a vaginal, you know, ultrasound history also you will ask whether maybe GP has done an ultrasound. Yeah. So I think most of you have said this is whether she has completed family history. Of course, when you take a gynae history, it will cover everything. I'm just trying to pick your brain when you see a patient gynecology, because most of the ST1-2 are not totally involved in the obstetrics. But if you see in the gynae, you gear your history, and most important history, don't miss it. Okay, so suppose I've just hypothetically told you, if you see on the left side, if you see this in the clinic, this is what? This is a polyp.
Polyp.
Yeah? Yeah. So a polyp can be removed with the polyp forceps. Can you see? This is small one. If she had an ultrasound saying that there is endometrial lining is fine, there is no endometrial polyp, Okay, so this is definitely an endocervical polyp. A simple polyp forceps to grab it and twist it, you can remove that. But if you see on the right side, what is this? This is also endocervical polyp. Can you see? It's a os, and this is a polyp. But can you see the difference between this polyp and that polyp? And this polyp is small, but this polyp is quite a fleshy and large, and there is a tendency to bleed. Okay, if you see such a polyp, obviously most of the polyps are benign, and so you need to decide whether you can remove in the clinic in the 2-week wait, or you book her in the colposcopy. Even though her cervix is normal, either you have a minor theater clinic, minor ops clinic, or bumps and lumps clinic like we have in our trust, or you have a in the colposcopy clinic you want to remove, because there is a risk of bleeding and you need to have either diathermy or something to bleed. In the left hand side case, if you remove the polyp, you just need to use some silver nitrate stick at the end to the base to stop the bleeding. Yeah. Okay, so what I'm trying to say is I'm not going to straight to cancer, because these are the real clinical scenarios you'll face. You will see 2-week wait patients. The GP has referred to you with an abnormal looking cervix, and we see all these cases. Okay, so the next one is the same woman. I'm just changing the topic. So she comes, her last smear in February was negative, high risk HPV negative, she's fit and well. Ultrasound is normal. And you examine bimanually and you see this. What's this?
Ectropion.
Ectropion?
Yeah, excellent. So you all have seen ectropion. So this is ectropion. So do you, the patient is worried. Some of the GPs, because they haven't done a lot of clinical attachment, and then they still worry about this ectropion and send us a 2-week wait. I mean, this is down to the teaching, isn't? That's why I thought at least I will bring this up. So the ectropion. So if coming to the last lady, she's although her mom has cancer, she's worried. All her swab is negative, her ultrasound is normal. And what you do during examination, what did you like to do in this case? You've seen this. Do you want to take a swab? Like a disturb the ectropion with a swab? You would like to see whether it is bleeding or not. Although she comes with a postcoital bleeding, so in the history, one of the important history is how much is the bleeding. If somebody comes with a postcoital bleeding, okay, they might have mild bleeding, they might have a heavy bleeding. Whether that bleeding is affecting her quality of life, all these are important in the history. So if it is mild bleeding, and because if we go back to the history, she is taking oral contraceptive pills. You see, the pills can give rise to an ectropion. Are the causes sometimes, because are you everybody listening?
Yep.
Yeah. Okay. Am I not boring you?
No.
All right. Sorry, I will come back to the cancers later, but I thought these are also important. So amount of bleeding is very important to make your decision. So if the amount of bleeding is less and it is not affecting her quality of life, you can reassure her and discharge her. If the amount of, if she's bleeding heavily every time, and you you can take a biopsy, or you can arrange a colposcopy and treatment of ectropion in the colposcopy room. So what does treatment involve in this case?
Silver
Has
nitrate?
anybody seen a treatment of ectropion?
Could you cauterize it?
Yeah, but you never ever do a ablative treatment, okay? Because some of the ectropion is always sometimes comes with abnormal CIN. So you always take a biopsy. So the next management will be, if she's bleeding, and at any if you think that she needs a colposcopy, you take a biopsy, and you always take you can excise with the tiny loop. It's not a proper big loop, but you can shave that area and the new skin forms. So you'll avoid intercourse, tampon. You'll give advice to the same like the treatment for colposcopy to women to advise to avoid intercourse, tampon, swimming, bath for 4 weeks. A new skin will form. But as far as possible, never ever go for most treatment. You try to manage conservatively, explain to the woman that it is nothing sinister. Because the more you treat, the more it affects the smear in the future. Yeah. Okay, so now the same patient, has everybody remembered the history? I'll just go back. So remember, she's 34-year-old, para 3. She's a smoker, and all the risk factors are there for the developing any cancer. And now the same patient, I've just changed the scenario. So she had a history in the past of CIN3, and her test of cure was normal in 2000. So following the treatment for CIN, we always use 6 months test of cure. So the test of cure was negative for high risk HPV. So now, because of our previous, we were not happy, we arranged for a colposcopy. And in the colposcopy, this patient, we find that she's a type 2 transformation zone. Everybody clear about what is type 1, type 2, type 3 transformation zone? Yes or no?
No.
Okay. So if I go back, so can you see around the red mucosa? This is the red mucosa, and this is the white. Okay, squamocolumnar junction. So if you see, this is an ectropion, but if you see here, the endocervical canal and the white here is visible completely. That is called type 1 So transformation zone is the junction between original squamocolumnar junction and the later, because a woman, as the woman advances in the age, as you see the menopause, close to menopause, the squamocolumnar junction, it recedes inside, okay? So if we see a junction here like this, clear endocervical canal, that's called type 1 transformation zone. Okay. Type 2 is, it will be inside the canal, but we can still see the squamocolumnar junction. Type 3 is, it's completely inside, we cannot see the squamocolumnar junction. Okay. So it's very important that when you look at the colposcopy, you're looking at type 1, type 2, type 3. So if it is a type 1 and type 2, where we can see the transformation zone very clearly, we call that as a satisfactory colposcopy, okay? So this means type 2 is, we can still see the endocervical canal here, it's inside, and yeah, and we can see in the colposcopy, there are different types of acetovite. So to see whether it is a high grade CIN or low grade CIN in colposcopic impression. So we felt that this is a lady, you can have, this is quite a dense CIN. There's a few abnormal vessels here. So we think it is consistent with the high grade CIN, okay? The colposcopy. Now we have not taken any tissue diagnosis. So what is the next one you want to do? So this lady, she has come with postcoital bleeding, and we found that there is a history of CIN in the past, and we have done although her last smear was negative, we have done a colposcopy because of the history, and we found this. So what are you going to do now? Any idea?
Let's.
Yeah. So there are two options. Because her smear was negative, you can do a LEDs, or you can do a punch biopsy to confirm. Both options are reasonable. If some of the units say try CN3 treatment, and then they do the loop at the same time, if they find, because they find that the is a high grade change. Of course, history is important. She has completed. You see that this lady has para 3. She's completed family. A second loop will not harm her much. Okay, but at least give a diagnosis. But if you think that it is an overt cancerous lesion, if you see, you should never do LEDs. You should only take biopsy. Or if you use LEDs as a procedure to take a biopsy, but you're not aiming to treat, if you find a lump or a suspicious growth in the cervix when you examine, okay? So has everybody seen punch biopsy? So the punch biopsy looks like this, and wherever you found that acetovite lesion, you have to go and just grab it. It is very easy. When you you attend the colposcopy clinic, you can have a go at it as well. So you just take a tiny, all the directed biopsy wherever you see the acetovite, and you wait for the histopathology result. The next option, somebody definitely mentioned that we can do the loop. So there are different types of loop available. I mean, depending on the bulk of the cervix. But if some women are nulliparous, very tiny cervix, you take a small loop. If it's a large uterus, you take a larger loop. Or the depth of the loop should be, if you're treating if you think it is a high risk, high grade CIN, and you're going to treat with the loop, your minimum depth should be 7 millimeter as per the BSCCP guidelines. So we have taken the loop as somebody advised, and the histology has come back as CIN3, and there is a focus of invasive cancer, 2 millimeter. So what's the next? I mean, I've just simplified it, but the histology gives us a detail, how far from the membrane and how deep is it, everything. But I'm just saying it is 2 millimeter. So what's the next one? Next step? Anybody? You all are doing very well. All the answers are correct. Just wrong answer will be okay. Vinod or Putri?
Follow up in 6 months?
Follow up in 6 months? No, you just see here, cancer is there. Can you see? Do you think the cancer is treated? What more questions you want to know? I mean, what more things are going to?
Would you do like a pelvic MRI?
Yeah,
Staging.
that's a good one. Yeah, I will tell you when we do MRI. That's a very good question. Yeah. Anything else? I just want to pick up the brain. Somebody has been diagnosed with a cancer. What do we do in the clinic?
MDT referral?
MDT.
Yeah, excellent. MDT, you all know. Yeah, justice has to come. What else? So in the MDT, what do they do? Have you attended an MDT? All of you should attend one MDT to find out. In your next time after this teaching, go and attend one MDT. How then your answers will come immediately. Yeah.
Do they
Okay.
stage the cancer?
Yeah, we have to properly stage the cancer. So the staging, I'll tell you, this is the stage 1, A1, A2 are staged by the histopathologist from the sample. We don't need A2, we need A1 is definitely only the histology can stage it. I will just go to the next one. So you have told lots of good answers, MDT, MRI. So, okay. So stage the cancer, MDT, yeah. But remember, these are not cases, these are patients involved, isn't it? With a cancer, it's a young woman, yeah. So it's breaking bad news, isn't it? You have to, and there is always cancer. No, there's a specialist, nurse specialist for cancer. They, as per the requirement, they have to be present while you are communicating the diagnosis. On the next day, within 1 to 2 days, you have to communicate to the GP that this woman has been diagnosed with cancer after you have told the patient. So in the okay, so we have a histology. So in the MDT, who all are the people in the MDT?
Oncologist, radiologist.
Hello? Oh, what happened? Recording.
Radiologist.
Well,
Hello.
yeah, something had happened. Yeah. Can you see the presentation?
Yeah.
Smita, are you okay, Smita?
Yeah. Something happened on my side. Okay.
We can still see the presentation.
All right, good. Yeah, thanks. So in the MDT, who all are there? Gynecologist, right?
Radiologist.
So there is local in the cancer, the treatment of cancer in UK. There are cancer unit, there are cancer center. So all the DGH I told you cancer unit. So cancer units have an MDT. Cancer centers have a network MDT. So cancer unit, the MDT is made up of radiologists who are specialists into looking into the imaging related to the gynecology. There are gynecologists whose core interest is managing suspected cancer in the unit, and there are histopathologists. Okay, so in this case, the histopathology is very important. Okay, so the pathologist, what are the important questions you'll ask to the histopathologist? Okay, I'll tell you this one. So before that, let me ask you a little bit go bit about the staging. So we wanted to find out the staging. We know that this is stage 1A, but I will just say, so the FIGO 2009 had, I just put a diagram to make you easily understand and remember. So if it is stage 1A, A1, which is less than 3 to 7, it is changed now to FIGO. The new FIGO has been changed, okay, 2018. But this was the original classification. It was the depth has to be less than 3 millimeter, and it should not be more than 7 millimeter in width. A2 is 3 to 5 millimeter in depth more, and B1, B2, you can see that it is still limited to the cervix, but it is less than 4 and more than 4. Okay, that was the and stage 2A is extension to the upper third of the stage 2 is again going outside the cervix to either upper third or parametrium. 2A is upper third of vagina, 2B is parametrium, and then 3A is lower third of vagina, B is extending to the lateral pelvic wall when women have all these hydronephrosis because of the ureteric obstruction, and then 4A, 4B. But this was 2009, okay? So in 2018, it has been changed because there was no, in 2009, there was no consideration of any lymph node status, okay? And there was no, so in 2019, the stage, essentially the change is there is no lateral spread, okay? Is not taken into consideration. The 7 millimeter lateral depth is gone. So either it is less than 3 millimeter or 3 to 5 millimeter is 1A1 and A2. And invasive cancer more than 5 is again going back to 1B. But 5 to 2 centimeter is B1, 2 to 4 is B2, and there is new addition of 1 B3, which is more than 4. So it is divided into 3. And then there is no change more in 2A, A1, A2, because again, there is a change in 3, which is addition of 3C here. So with pelvic lymph node metastasis is 3C1 and para-aortic is 3C2. So any of the B1 cancers, if they have pelvic node, they go back to 3, although the size may be less. this is too much. Okay. So all right. So can you see the differences from now? Now we are saying it is stage 1A. The horizontal spread is no longer taken into account. Yeah. Yeah. Am I telling too technical? No. It's very easy. Okay. So B1, B2, B3 is again depending on the size and that as yeah. And 3 there is addition of 3 C1 and C2 because now we are more and more doing we are no longer doing I'll tell you the procedure how we stage the cervical cancer. So FIGO recommends that you can do a physical examination that we do in the 2-week wait clinic as well, and bimanual examinations, speculum examination. If you see a big lump, we can take a biopsy there, like a punch biopsy sampler. We don't have to go to the colposcopy. And there are cystoscopy, endoscopy methods where to see whether there is extension to bladder or bowel. There are imaging, there are image-guided biopsy. But there is no recommendation for any routine investigation. All the FIGO has given the freedom to the clinicians based on the resources available and standard of care. But in UK, if we can diagnose clearly on a MRI and a clinical examination, we don't need examination under anesthesia and cystoscopy, which used to be our teaching in the past. So if there is any discrepancy when we say that, okay, this is a stage, looks like a stage 3A or MRI says different. If there is discrepancy between the MRI and our clinical findings, then we have to do an examination under anesthesia and cystoscopy. And there was also in FIGO and worldwide in India, they all do this examination under anesthesia, cystoscopy. You know, there's a lot of centers also do when there are to do the staging, but it has, and even sometimes the surgical staging, they go inside and look at the lymph node involvement, lymph node biopsy, but that is not shown to any improve the survival. So case 1, again coming to the case 1, as I was asking you, you know that the staging, now for the staging, she has been confirmed, a loop sample has been sent to the lab and the histopathology said stage 1. What are the important things you want to ask in the MDT? I asked you because you want to know whether, you know, she's completed the family. So most probably this case, she might opt for she might not opt for any further treatment, or she might opt for a simple hysterectomy. But you want to know whether you can offer simple hysterectomy or not. So you want to find out, these are the questions you want to ask. Okay. So it's very important. Suppose you are in the clinic and you see a patient whose loop excision has come, you know, it's very important to look at the detailed description of the histology, whether the loop is oriented, whether it is fragmented, and is the margin clear? Okay. So remember, if the margin may be clear for the cancer, if the margins are positive for CIN, then also the patient with stage 1A need a re-loop. Yeah. And also you have to ask about whether lymphovascular space invasion is present or not. If it is present, then she will need, I will come back to the management. Okay. So these are so you're looking at, sometimes the loop is taken into 2 pieces. It is not well oriented. It is, you know, in those cases, you can't say that even though the histologist says this loop, this fragment had 2 millimeter cancer and it is a stage 1A, you cannot take it. Okay, so then somebody was saying about MRI, right? So if it is stage 1A, A1, and we are very sure that the loop is a clear loop, it's not fragmented, everything normal, then MRI and CT doesn't have any role. So we can if somebody has completed family, we can offer that. Or if she wants to, she's not complete the family, then you can still a cold knife and loop is an acceptable treatment. Okay. So you will offer a re-loop, re-cone knife, which is called conization in the terms. The term is called conization. So if the margins are positive for CIN, and if it is fragmented, then you always do a re-loop. Everybody clear? Am I boring everybody?
No, it's
Say yes or no. I will take no as a not getting bored. Silence.
All clear, and we are not bored.
Oh, thank you. Okay. So nowadays, if there is a lymphovascular space invasion present, then of course she needs a referral to the specialist center. You know that there is cancer unit and cancer center. Only straightforward, A1, we are happy to treat her here. But if it is lymphovascular space invasion, then this is called sentinel node biopsy, lymph node biopsy, and they might perform a pelvic lymph node dissection as well. And also you have to counsel the woman that if you're doing a re-loop, there is high risk of obstetric complication and she will need a cervical length measurement. So nowadays I see lots of women who are in the antenatal clinic had a loop. So when will you offer cervical length? What are you going to check in the clinic? This is an important question for you because you all do antenatal clinic. Any idea?
After
At
12
Suppose
20 weeks,
pregnant,
it's routinely checked.
before 20 weeks.
you will monitor the cervical length until 20 weeks? That's what you said?
Do we not do them between 16 week to 18 weeks? But we do them twice, isn't it? In antenatal.
Yeah. But I'm asking, if somebody gives you a history of loop, in your trust, she had a treatment, what will you want to find out before offering cervical length measurement?
Do you go back and look at the histology?
Yeah. Okay. If histology is one piece and is less than 10 millimeter length, then you just have to counsel that there is a small risk of having early delivery, not after 35 weeks. So will a cervical length will help? No. So yeah, and most likely if there is only one loop, the chances that they need a cervical measurement is 0. If there are 2 loops, obviously, and if they have a invasive cancer or something and they've taken a cone biopsy which is a longer length, then obviously. But the recent guideline is if it is less than 10 millimeter length, because the loop will tell us the length of the cervical. If there is no more information, she has done it outside somewhere, then it is probably safe. If it is one loop, I still think that you don't need the cervical length measurements. If it is 2 loops or a cone biopsy, you don't have the exact measurements, then you definitely offer cervical length measurement. And it is the 2 measurements you said. Yeah. Okay. So this is regarding stage 1A1. So case 2, see this lady is a nullipara, had a colposcopy loop for severe dyskaryosis, and the histology is reported as adenocarcinoma stage 1A2. And the margins were negative, and lymphovascular space invasion is present. And she's keen to preserve fertility, wants to have children. So first of all, whatever management I'm saying, these are all now, it is as soon as it hits stage 1A2, you do the basic workup here and in the unit, and those who are not in the, you have to refer to the specialist MDT in Cancer Center, which is in the Oxford, and for Wrexham we have Imperial College. So what do you think? Can you offer them? Any idea? Okay, so I'll go back. So you always discuss these cases in the unit MDT because you know that we have to find out exactly what is the tissue like, what's the margin, and how far it is from the surface, how deep it is. And always, if there is a lymphovascular space invasion, even if there is stage 1A1, they need to go to Cancer Center Specialist MDT for discussion and management. So in your unit, you for the assessment purpose, you examine, you do vaginal along with a bimineral examination because you want to exclude any parametrial extension. If it is a thin belt, you can assess clinically very well. So now she had a loop treatment, right? And she needs MRI. First, any patients above stage 1A1, you need MRI to find out how far the tissue has spread. Is there any other for staging? So when will you offer MRI? Any guess? Just blind guess. 1 day, 2 day, 1 week. Is everybody listening? Hello? Hello?
Hi. Would you not go with what the radiologist says? Just do what they want? Or do you have to make the decision yourself?
Oh yeah, radio, but you should have some because the patient will come to the clinic, you see. Because nowadays the 28 days diagnosis, you have to, and 62, there is cancer pathway. Your MDT will be next week, you see. You have the histology now in the clinic, yeah, or somebody had a treatment and they asked you, report comes to you.
Yeah.
Or you see the patient, she has not passed by the MDT. I'm just saying for your knowledge, because nothing in all these cases, you just need to know the, So it is at least 7 to 10 days, okay? Because if you have a loop, already there is tissue, scar tissue and the inflammation from the treatment that may misdiagnose the extension and the staging. At least 7 to 10 days after you do the MRI. Hello? Yeah? Any question? Yeah? Lydia?
Yeah.
You are asking something?
No, that's clarified it. Thank you.
Yeah. And so always with any cancer management, first thing you discuss in the MDT, you have the detailed history, you have and then obviously after the MDT, you meet with the patient, with one of the supporting partner or friend or whoever has to come, and you break the news, you tell them this exact what the next step is, and the same time you communicate with the GP what you have told to the patient and what is the next step. And there are lots of Macmillan information about all the cancers support, and there are lots of support available, and you will see in the next I think Bal has arranged for you. So we go through the detail, and it takes around a long time to give them the contact details if they have, because it is such a for a young woman to have a diagnosis of cancer is quite devastating. So obviously they will not remember much and they will ask after going. So we always give the CNS contact details. Okay, and then in this case, especially we refer to the Cancer Network MDT, where the histology will be reviewed and the imaging will be reviewed. They will have a final staging, and as well as the treatment will be discussed there. So my next slide will be what they will offer them. Okay, so women with stage 1A2, this lady who wants to preserve her fertility, you can you can offer radical trachelectomy, simple, depending on lots of high risk factors they assess. Okay. But in her case, there is lymphovascular space invasion also there. So one is one of the high risk. So they might even offer her trachelectomy with lymph node dissection, which I'm not going in detail. But most important is every woman is different. They have to individualize the treatment and they have to have a counseling detail, because the important prognostic factors are the size of the tumor and the lymph node. So there are in FIGO, there are early stage cervical cancer, the stage 1A1 till stage B1 is the early stage cervical cancer. So basically they all need these treatments. It's a radical hysterectomy with bilateral salpingectomy, or if they're older women, they can offer oophorectomy. But remember, this lady who had a adenocarcinoma, right? So if we have to leave the ovaries, even with trachelectomy, we have to counsel her that there is a high risk of metastasis to the adnexa, to the ovaries, because of the adenocarcinoma. Yeah. So now this is a lady who, again, she's a 46-year-old. This is a real case I saw. So this is a 46-year-old presented to A&E with irregular vaginal bleeding and living in nursing home for mental health issues, type 2 diabetes, hypothyroid, and speculum examination could not be done. So he arranged a scan and then asked the next day, I think the appointment was seen. Okay, so can you see we have, despite our NHS screening, we get lots of patients. I mean, when somebody examined we found quite a irregular and nasty mass, very smelly in the clinic, in the 2-week clinic. So never ever think that women who are even nullipara, they are single, they never had intercourse, can never have cancer. You never know. HPV is the important one, but she might have some other incidents. She has a lot of mental health issues. So never had smear. And everybody started thinking that she has irregular bleeding, and then she comes with extensive cancer. So this lady, because we couldn't examine in the clinic, I gently examined with one finger, and it was quite suspicious of cancer. So she has an examination under anesthesia, MRI, and a biopsy. So we find this. You see, if you find this, where will you take the biopsy from? Why it is important? Yeah.
The margins.
Yeah, margins. The center will be quite necrotic, you see. So it has happened many a times that obviously these are advanced cancers, and I'll come back to you. The advanced cancer management is chemoradiation, and so the cancer treatment will be delayed because we haven't taken a good sample in the biopsy. Because sometimes you don't have to have an examination under anesthesia if you can examine in the clinic. So we need to take a good biopsy, and most of these masses, they don't bleed. So we can take with a punch biopsy with the other biopsy as well and arrange MRI, and the cancer, the treatment won't be delayed. Sometimes we don't take a good sample and then we know that it is a cancer, but we cannot start treatment without a biopsy sample like any other even advanced ovarian cancers. So for the locally advanced cervical cancer, which is from stage 1B3 to 4A, the treatment is chemoradiation. Yeah, but in the if you go through the strategy, the e-learning module, they say that in one of the stages it can be both have equal either surgery or primary chemotherapy, both can be given. I mean, either or can be given because there is no studies showing advantage over one over other. But most important is we want to avoid a concurrent treatment. Suppose she had a surgery and she needs a post-operative external beam therapy, which increase the morbidity and quite a lot, and where there is no impact on the survival. So that's the cancer gyne oncologist in the cancer center, like Human and other center. They assess which of the patients they are highly likely to be managed by chemoradiotherapy or the early cancers, stage 2A, A1 and B2. But B3 and A2 are, you remember, this is 4 centimeter and above. B3 is more than 4 centimeter and A2 is also more than 4. So the larger tumors, they definitely need chemoradiotherapy, because even if you do the surgery, the margin won't be clear. They will need a post-operative therapy, which increases the morbidity. But are you clear on this topic? So the management of early cancer, you definitely do the operation, okay? But the 2A1 and B2, whether you do chemoradiotherapy or in the strategy, you will see that both have equal. But there are a lot of other issues, other high risk factors which are considered before they offer the treatment. So the high risk factors are all this. You see how much is the spread, whether, so if it is a stage 2A cancer, but this has pelvic node that goes to stage 3. I think this is just for your information. You don't have to remember, but the basic thing is important is when we can treat in local cancer unit, and what are the treatments they offer in the tertiary center. If the patient asks you, at least you can say something, and you should have some knowledge of what we offer in the tertiary center. Any questions? No? Yes, no? Mal?
Yes, Samita.
Yeah,
That's great. Thank you. Shall we have just a short 10-minute break, maybe 10-15 minutes? Let everyone just stretch their legs and then we can carry on with the second part. Is that okay?
Yeah. Well, I didn't want to do two. That's why I added all these ectropion, polyp, because I realized that ST1-2